welcome to the Home of Medicine podcast with me, Dr. Amy Burbridge.
And me, Dr. Ben Lovell. Hello.
Welcome back, everybody. So, Ben, you have a case for me.
Yep, are you ready?
Absolutely.
So this is a case of a patient who came to the emergency department and then to the medical take. And a big shout out before I forget to my wonderful colleague, Professor Michael Marks, for helping me with this case. So this is a 48-year-old lady. She was born in the Gambia, but lived her whole life in the UK. And she came in due to a headache. She was well yesterday. She woke up today, the day of presentation, feeling a bit under the weather, but non-specifically so. Then she developed, over the course of about an hour, a worsening headache to the point where it was profoundly severe. She developed a fever of 38 degrees and said her neck felt stiff and she didn't like the light. That was how the patient was bundled up for me to come to see her in ED. She had no confusion, disorientation, no focal neurological impairment, no seizures at all. So fever, headache, reported neck pain, stiffness, and sensitive to the light. And on examination, she was photophobic. She didn't like the light being on, and the neck was very sore. A quick scan of her history showed that she was a type 2 diabetic, maintained very well on metformin. She was also on ramipril and atorvastatin. But otherwise, apart from that, no major medical problems in her past medical history. So I went to examine her and she was tachycardic actually at 136, sinus tachycardia. And this is in the context of a fever of 38 degrees. Her blood pressure was 90/54. Her respiratory rate was okay, 21, and her SATs were normal, 99% on air. And I examined her looking for infection causes, and her chest was clear. Her abdominal exam was fine. She had no focal neurology. She had no rashes on anywhere on her body or any nail changes, and she had no lymph nodes raised that I could feel. And I went to have a look at her neck, and she said, oh, it's very painful. The muscles are very sore all up and down my neck. And I tried to move it around, and it was pretty stiff. And I was trying to work out whether she had decreased movement at the neck because her neck muscles were painful. She didn't want to move it, or whether she had true nuchal rigidity. And I did something that I learned a long time ago, a little trick, which was to lie her flat on the bed, then just put my hand behind her head and lift it up. And if her upper body comes up with you, patients don't like this, by the way, because it hurts. So do it very quickly. But if you lift up the head and the upper body rises as well, that usually means the neck is stiff and locked. That's true meningism, really, a true neck stiffness, rather than the ow, 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 my posterior neck muscles are really sore when I do that. So differentials at this point.
Okay, so when I've got a patient like this, the first thing I need to do is, what life-threatening condition could this individual be having? And given the headache, the meningism, and the fever that you said, my first diagnosis is meningitis. So I would need to make sure that she doesn't have meningitis, whether it be bacterial, viral meningitis. If it was bacterial, is this a pneumococcal meningitis that would require intravenous steroids? Or is it a bacterial meningitis, such as Neisseria meningitidis? Other conditions that this could she have the flu? So influenza can be pretty grotty. It can give you this neck stiffness, generally feeling awful. You said that she hadn't travelled anywhere recently, so I'm not too concerned about something like malaria that could be possible there. Again, the sudden onset of a headache, is this something like a subarachnoid hemorrhage? Doesn't really fit the picture with the photophobia and the fever, so that's less likely. Migraine, photophobia, neck stiffness. No, I'm stretching it really there. I guess that's where my thoughts are at the moment. I'm looking at her medications thinking, could it be anything to do with this? But I don't really think it is. Initially I thought, could she have hypertensive crisis before you'd told me about her blood pressure, but she's hypotensive, so I'm not really concerned about that. So I guess that's where I am at the moment.
Okay. Yeah, basically I was trying to make a decision at that point saying, am I going to have to get the lumbar puncture pack out or not? Any strong preferences from you, or not enough data yet? The LP or not?
I do sometimes think that we delay LPs
Mm.
Um, Probably unnecessarily because we're busy. It takes a long time. We can't find the kits. Mm. I reckon if I had this patient in front of me with this history, this heart rate, this temperature, the neck stiffness, I am going to treat for meningitis. I am going to give her intravenous antibiotics in resus. Therefore, I need to do an LP.
Okay, you've convinced yourself.
I've convinced myself, but I might be wrong.
Brilliant. So I ummed and ahed for a good couple of sleepless minutes and looked at her blood test results. Her CRP was 14.14. Her white cells were 2.9 and her neutrophils were 2.4. Her lymphocytes were down at 0.4. Everything else was normal. I went back and had a look at her again. I was like, if she's got bacterial meningitis, she's supposed to be sicker than this. She's supposed to have a higher CRP than this. She's supposed to have why has she got a lymphopenia? That smells viral to me. And I often have this sort of dialogue in my head saying, well, if I think someone's got viral meningitis, for which treatment is conservative, bit of fluids, painkillers, you don't need to do a lumbar puncture for it. And I don't do lumbar punctures lightly because the way we work, I see the patients where they go wrong. If you have a lumbar puncture and you don't have any side effects, then you never come back to a doctor. But because if you have a spinal hematoma or a severe post-lumbar puncture low pressure headache, you come back. So it's very easy to get into bias going, oh my God, there's so many side effects. It's such a risky procedure. But you have to remember, we see the tiny minority because they seek medical attention. But it does flavor my decision making, I have to be honest. And if it was a viral meningitis, where was the rash? Where was the meningococcal septicemia in the rash is the other thing. So I ummed and ahed. I thought, well, there is data saying that we do late LPs in bacterial meningitis, and I don't want to join that data. So lumbar puncture it is. And if we're treating for meningitis at my hospital, we give a third generation KEF, which is ceftriaxone because it crosses the blood-brain barrier, and a bit of fluids for her blood pressure. So, and the other thing which slightly pushed me was that blood pressure of 90/54 was a bit low, and it wasn't responding to fluids. She had 1 liter, 2 liters, third liter going, and she was still a bit hypertensive. And that's when I start thinking, could it be sepsis? Because this persistent refractory tachycardia hypotension, have I actually got someone here in septic shock who's heading towards septic shock that needs treatment? So that, I think, finally pushed me over the edge to the lumbar puncture. But I had the same thoughts with you. Subarachnoid hemorrhage, it wasn't true thunderclap. Why she got a fever? Migraine, why she got a fever? So that's why I went for CNS infection. Does that make
Yeah, I've just wrote down 2 things. I've got lactate and pregnancy test.
Oh, good thoughts. Pregnancy test was negative, so she's 48.
Yeah,
You could, still of childbearing age, and the lactate
absolutely.
wasn't raised. It was like 2.1 or something, which is just the upper limit of normal.
And was
So
the pH okay?
pH was normal. Yeah.
So I guess when you're thinking about the sepsis picture, her lactate's okay. Urine output, was that okay?
I'm afraid I don't know. Actually, she didn't have a catheter, and she was still in the stage of pee when you want to in
Yeah.
the department. Yeah.
Yeah, I suppose so that's one thing you could think about, I guess, is urinary output, but blood pressure's a little bit low. She is tacky.
Mm.
Respirates on the higher side. Was it carbon dioxide and PO2 normal?
Yes, they were normal.
Yeah. So I think, yeah, in the situation, I think I've convinced myself to do an LP. However, your blood test that you've given me with the lymphopenia, the white cell count is low as well.
Yeah, it is slightly low. Yeah.
Yeah. Is this flu? I'm thinking influenza.
Yeah.
I'm thinking COVID because I say COVID for everything now because I've literally seen COVID in presenters, anything and everything over the last 3.5 years. So I guess I'd be thinking about, do I need to do a COVID swab potentially?
Yeah.
But ultimately, I'm going to do an LP.
She got a COVID swab as is practiced, and that was negative for what it's worth.
Okay.
So yeah, and it was the neck stiffness, and it was the blood pressure. So she has an LP. The LP wasn't that straightforward. It was finally achieved with her in a sitting position. So that means no opening pressure. Opening pressure obviously only being available when the patient's lying down with their spinal column parallel to the floor. So and it was a slightly bloody tap, and it goes off to the lab, and it comes back a couple of hours later, and it was a bit disappointing, really. Her white cell count in the CSF was less than one white blood cell. Her red blood cells were 1,000. And unfortunately, protein, too blood stained for protein analysis. So I couldn't get that. And the glucose was 3.0.
What was her lab glucose at the time?
Lab glucose at the time was 6.9. Why do you ask?
So, well, number one, I mean, I talk about my bugbears a lot. I mean, I seem to have a few, but one of them is not doing a lab glucose at the same time as the CSF glucose. And if you want to look at the glucose and if you've got a bacterial infection, your CSF glucose is a lot lower than your lab blood glucose, for example. Whereas if it's a viral infection, you don't often get the glucose to be as low as a bacterial infection, particularly TB as well. That can often lower your CSF glucose. And I always think about that this bacterium is really hungry and it's just eating all of the sugar. And that's why the glucose is a little bit lower. So that's why I always ask about that. So 3, I guess, is a little bit low.
I've got in my mind it should be more than 2/3 of your serum. So if her serum 7.2 and her CSF is 3.0, actually that's less than 50%, right? So
it's low, yeah.
That raises an eyebrow, I guess.
It does. I'm starting to think, is this bacterial? Although the white cells are low. Had you given her antibiotics at this point?
Yes, she'd had her shot of Kef already. Yeah. Yeah.
Okay.
Yeah. I'm mindful that there were, well, in an ideal world, you do your CSF before you give antibiotics. I just don't see how that's ever feasible. And I think delaying antibiotics can have a significant mortality impact on patients. So I don't know. You can get your blood cultures, maybe. You should be able to get your blood cultures before you give antibiotics, because you're putting that cannula in to give the antibiotic. And as the cannula goes in, the blood culture comes out. So you should be able to access blood cultures. But yeah, she'd had antibiotics at that point. So I thought to myself, see, one less, well, I didn't even say one blood cell, less than one blood cell, that's 0. So that is, everybody stands down. This is not a CNS infection, because where's her white cell response? That was my sort of reasoning at the time. But on reviewing the patient, she was still persistently hypotensive. She had 4 liters of fluid and was maintaining a BP of about 95 systolic, which is not, well, it's not good at all. And at that point, I was like, she is not responding to fluid. And I'm going to have to call ITU for someone with a non-responsive blood pressure. And if I think I've ruled out meningitis here, what on earth is driving her persistent hypertension? It's shock, right? She's in shock at this point, tachycardia and a fluid non-responsive hypotension. She's not hypovolemic shock. She hasn't lost any volume. Is she in septic shock? She's got a high fever. She felt warm peripherally. Is this sepsis, the vasoplegia and the loss of peripheral resistance getting sepsis? And if so, if I don't think that sepsis is flooding from her meninges, where is that sepsis coming from? So she was referred to ITU, and she was actually taken to ITU for a bit of peripheral vasopressors, the metaraminol, to just support her blood pressure while she underwent further testing. And it was in ITU that another result came back, which was meningococcal PCR on the CSF came back positive. So she has meningococcal meningitis, Neisseria meningitis. So this is someone with meningitis, but a meningococcal meningitis, not only presenting slightly oddly because she didn't have that rip-roaring sepsis, that horrible meningococcal septicemia with ischemic limbs and the big florid rash, but she also had no pleocytosis, no white cell response in her CSF. And a couple of things for me, which I found strange. I was speaking to ID. Number one, I didn't know I was going to get meningococcal PCR back so quickly, but I was shown what the new testing kits look like, which look a bit like the LFTs we did for COVID, like these spot tests where you can put them in and you get a turnaround time in an hour. And I think I'm more familiar with the ones that take more than 24 hours to come back, a bit like your HSV PCR when you're thinking someone has viral encephalitis. But apparently these kits are becoming more and more common. Is that something, have you ever done this in your trust? Do you know which ones you use?
No, I don't actually. I have seen a couple of Neisseria meningitis, normally in young women as well, actually, which is interesting. But no, I actually don't. I'm not aware of the tests that they do for that and the PCR and whether it is a rapid test or not. I always assume that if I send off an LP, it's going to take 24 to 48 hours for any meaningful sort of cultures to come back.
Yeah.
Just because, yeah, but maybe that's something I need to probably follow up actually. That'd be really interesting to look at. Can I ask, what was her CRP?
14, 1-4.
Oh, 14, yeah, you said, didn't you? And she wasn't immunosuppressed.
No.
Okay.
Well, no, she
Kidney
wasn't
function.
suppressed by medication, but she had diabetes, which is
Yeah.
slightly immunosuppressed state, isn't it?
And was her kidney function okay?
Completely normal.
And what was her job?
Oh, she was a full-time mother to, I think,
Okay.
3 or 4 children.
Okay. So I'm just thinking about where could she have got it from? Could it have been one of the children, or was she working at a university surrounded by lots of young people? Okay. Really interesting case. I think, that completely throws our biases out of the window for what Neisseria meningitis looks like and what it doesn't look like, actually.
I had a conversation with the ID team and I said, can you explain to me how she can have meningococcal PCR
Mm.
positivity with no white cells in the CSF? And they said, oh, you did it early. So you did the LP so soon, the white cells had not yet migrated into the CSF space. Plus,
Really?
slightly low white cell count anyway, just was probably not for her. But yeah, she said you did. I think the LP I did it like 6 hours after she developed the fever, the headache, and the stiff neck. She said probably if you did the LP tomorrow, it'll be chock full of thousands of white cells, polymorph. But when you do it in the first few hours, yeah, it can give you a falsely negative CSF reading, yeah, which was complete news to me. I hadn't seen that before, and I thought that would be an important point to get out there because if you don't have access to same day meningococcal PCR, or if you didn't even send it, if you didn't think to send it, and you were waiting for the cell count to come back, I can imagine myself or someone else stopping the KEF,
Mm.
thinking, well, we've ruled out CNS infection now because look, less than one white cell, so this isn't meningitis, and that patient coming to harm. So I guess I thought this case would be interesting because number one is send meningococcal PCR when you're doing the case, and also if the patient's quite early on in their sickness in this process, you may get falsely negative cell counts in your CSF. So bear that in mind. If the patient looks like meningococcus, so they've got that rip roaring stiff neck and the meningism, you can keep treating whilst waiting for more data to happen, or even consider repeating an LP if it doesn't fit. And maybe the next day after the patient's had more of a time to generate this kind of white cell response. And I guess we both clicked on that glucose was a little bit odd, that low CSF glucose.
Yeah, absolutely. And I think when you've got a case like you presented at the beginning, one of the things I do is what I talked about was what is the most serious life-threatening condition that this patient could have.
Mm.
And we mentioned meningitis, and like you said, you treated as such with a ceftriaxone, which is always the most sensible thing to do because the risks of not giving the ceftriaxone are much higher than the risks of giving the ceftriaxone in this case. So,
Yeah.
yeah.
The tricky balance, I guess, is approaching a patient with the what's the most life-threatening condition? How can I do that first, and not
Mm.
treating everybody for a life-threatening condition, and maybe over investigating or over diagnosing.
Yes.
Um,
Yeah.
and that balance can be tricky to get. And we've talked before in this podcast about a phenomenon called recent case bias, which is when
Mm.
recently it sticks at the front of your brain and you start
Yeah.
to see it everywhere. Or more commonly, if you miss something and that's left a bit of a psychological wound, you will think of
Yeah.
that first every time, even when it's not clinically appropriate. I remember a very long time ago when I was an SHO, I had a registrar who insisted that every patient had a breast examination. And when I finally said, why? What for? You went, oh, there's one case we missed a massive fungating breast tumor with an abscess, and I just don't want to miss it again. And I didn't have the words for it at the time, but I now realize that was a previous case bias, recent case bias, which then meant that people were getting a little bit of an over investigation when they came in. Um, a non-invasive investigation, but maybe if the over investigation is imaging, maybe if you
Mm.
become someone who CTPA is everything, or someone who CT heads everything, or maybe even just as a lot of lumbar punctures because you had one
Yeah.
case where you wish you'd done it. And we often try and right that missed case, right that wrong by doing it a lot thereafter, because we don't want to miss case number two.
Yeah.
It's tricky to unpick recent case bias, and I think the only way forward is really healthy reflection with someone who is trained in facilitating reflection, and teasing out learning from it. Because I think without reflection, it can turn into just reliving the same trauma over and
Yeah.
over again.
I
It's
guess that's what we do on the podcast. We talk about cases, don't we? And we reflect on them and we learn from them. So I'm not telling everybody to go out there and start a podcast, but certainly finding somebody who you gel with, you can have a conversation about cases with is really important. And also who's non-judgmental. Because I know in the past I've spoken about cases where I've missed things and then somebody's like, well, I can't believe you didn't get it. And I'm like, that's really not what I need to hear. Actually, what I need to hear is, okay, so next time, this is how we could do things differently. And you raised the point of recency case bias. And I had way back when I was a foundation doctor, I'd like to say it was a few years ago, but it was nearly 20 years ago now. I saw a young gentleman and he presented with confusion. He's very young, background history of psychosis and schizophrenia, and he'd had this new confusion, had a bit of a headache, but obviously, of course, the cause of his confusion and his headache was obviously his psychosis and his schizophrenia, clearly, because I was an F2 and I had no experience. So I somehow managed to get him a mental health act assessment in the middle of the night. I don't know how I did it. It was an ED. It was, as they say, a long time ago. And the next day he came back into hospital. He'd gone to the local psychiatric hospital. He came back in when I was back at home asleep in the day. And I found out the following evening, he came back in and he'd actually had a subarachnoid hemorrhage. And what I'd done is I'd made the diagnosis of confusion, secondary psychosis, schizophrenia incorrectly because he was schizophrenic. So it must be schizophrenia. Obviously, schizophrenia does not present with confusion. I didn't have the knowledge. I'd been a doctor for a year. I didn't know that. Every single patient who came to the emergency department for about 6 months, I scanned their heads. So then tell me what you come to hospital with. I've got a sore toe. Excellent. Let's scan your head because I don't know whether I'm going to miss a subarachnoid hemorrhage or not. And I was absolutely petrified. I was almost paralyzed by it. And I could not think past it. And it was only when I left working in ED and I moved on to IMT1 training, as it's called now. Back then it was called medical training, that I had a bit of time to reflect and talk about it. But it actually did paralyze my decision-making process. But actually what I've realized now is I lacked the knowledge, to be honest. I lacked awareness of what bias is. But I mean, I don't know how many heads I scanned. It was absurd. But it was I was so petrified of missing another subarachnoid hemorrhage. It was awful, actually. I've got past it now. My knowledge is better. But at the time, it was pretty scary.
I think one thing that helps as well, which is what we try to do on the podcast, is for senior clinicians to honestly talk about mistakes or errors or biases they've had, to show that you do not have to be infallible. I think a lot of time when people make mistakes, it comes with guilt, saying I should be better than this because, at my stage I shouldn't be making errors. And let me tell you something, at any stage you can make an error, because those big pink blobs of flesh in our skulls, don't process things perfectly every single time. And whenever I go to conferences, the ones I really enjoy, they even have a session about a mistake I made in my practice, delivered by very brave, very honest senior consultants, and say, here, an error I made. It could be a long time ago, and I think just presenting it like that, so people know that mistakes are everywhere and mistakes are human, and you cannot punish someone not to make a mistake. You cannot practice to never make a mistake. But I think laying it bare and talking about why it happened, talking about how we try and make sure we don't do that mistake again, and talking about learning we can pass on to others, which might help them in their own clinical practice, I think is really important. And I don't think this existed 20 years ago. I don't remember ever hearing people I look up to and respect who are quite senior in their careers talking about mistakes. But I think maybe it's becoming a bit more prevalent now. And I think that is a good thing. And I think, as you know, this is something we do try to do here on the podcast. And if someone hasn't, this is the first episode you're listening to, go back and pick one, and you'll find a collection of stories where Amy and I talk about this sort of thing and talk about how we work through it, and how we would like you to work through it if you came to a similar case in your practice.
I think really what makes you a good clinician eventually is the ability to reflect on the mistakes that we make, because every mistake I've made, and I still make them every day because that's life, you learn from it and you share the learning from it as well. And that's what we try to do in the podcast, isn't it? We try to reflect on our mistakes and our good things and learn from it, definitely. But it's a process, isn't it, really? It's to getting there. But I think what we often don't recognise enough is decision fatigue. So, for example, I went to work Tuesday this week and I'd worked the weekend, and I turned up and I was just completely and utterly overwhelmed by the number of patients I had to see. I just, when you get that sort of, I can't do it. I don't know how I'm going to see all these patients. There's too many. How am I going to make decisions on all of these patients? I think by about 2:00 in the afternoon, I actually couldn't function. I couldn't make decisions. It was taking me ages. And I think that's one of the first thing that happens to me is I'm quite slow anyway on a ward round, but I was even slower, and I was struggling to even speak and write and verbalize those things. It was exhaustion, really. And that decision fatigue set in, and I just had to take an hour away. I just had to say, I need some food, I need a coffee, I need some chocolate, I need some time out to give me some energy, to give some glucose to my brain. I think I was neuroglycopenic. My brain had used so much glucose trying to make these decisions. I was like, I need some chocolate. Luckily, the time of year, it's festive at the moment. There is a lot of chocolate around. But I think we don't talk about that enough to our trainees, is that actually at 4:00 in the morning, when you have night brain, you can't make decisions actually. And it's really hard. So don't be too hard on yourself. All you need to do is keep that patient safe. You don't need to diagnose that adult onset Still's disease, that really obscure Kawasaki's disease. You just need to keep them safe.
I love how everyone else gets hangry, but Dr. Burbage gets neuroglycopenic. But I completely understand what you're saying. And it's a lot about, you can spot it in others who are decision fatigue, or if they've maxed out their cognitive load or whatever, and they start to show signs of it, and that's irritation, that's
yes,
all the things you're saying. Literally, I can't form a coherent sentence because my brain's and that just tips, if you have any, but tips I always share, if you can sense yourself or you can see it in your colleague that they've maxed out, they're using every available cognitive channel they've got, and they're starting to melt down. Tips I share is, number one, try and introduce a digitally sterile ward round. Get everyone to put your phones on do not disturb mode, because when you are concentrating and you are overwhelmed, just even having your phone on silent buzzing in your pocket, it steals your attention. It just takes up another one of those cognitive channels, and then you think, I've got to check that now. That could be an important call, or what's this email? So introducing that sort, like they do in cockpits, they have digital sterile cockpits, so no one has been distracted by bings and bongs and buzzes. And the other thing is, it's about, as you say, it's about breaks. We still believe that you should get a break if you can, and that's wrong. And if we reframe breaks as patient safety rather than just a nice luxury, like, I've got to take a break so that I'm safe. And it might seem crazy, like, what do you mean you can't do a walk around? You've had a cup of coffee. What kind of caffeine addict are you? And it's like, it's not about the caffeine so much as I need to close down a couple of channels here because I am maxed out. I need to be quiet for 10 minutes so I can speak English again, and recognize that other people and sending them away to have that. And it's got to be okay to do that, I think. And also basic needs, toilets and food.
About the coffee. So the coffee thing, I always about 10:00, I'm like, I need coffee. And the lovely doctor who I'm with will always like, shall I go and get you one? And I'm like, no, I'm all right, I'll go and get my own. And I'm like, would you like a coffee? No, I'll get you a coffee. You have this little debate. And I actually have to get my own coffee because I have to leave the ward.
Yeah.
And I have to physically walk to the shop at work and take 5 minutes away from the ward, away from the beeps, the bleeps, the noise. just to take that 5 minutes of downtime before I go back on again.
Yeah.
That's really important.
Giving bleeps away, can you hold this bleep for 10 minutes? I need you to hold this bleep for 10 minutes. I say to red reggers as well, who are being bombarded with bleeps and saying, if you need your break and you're worried about not having a bleep because it's a crash bleep and you need to know, you can swap it with someone else, swap it with the SHO for literally 10 minutes. They can write down a referral on a bit of paper. They're highly trained professionals, that you can trust them with that, and you can hold their SHO bleep, which maybe doesn't go off as much, and you can just go and take that break. But I think recognizing cognitive bandwidth being saturated in oneself and one others is absolutely crucial, and it's a patient safety issue.
It is a patient safety issue, and I knew when I went to work on Tuesday, I just wasn't thinking. I just wasn't able to function, and I sat down, and I never do this, but I cried at work. Well, I do cry at work actually. I say I never do, and not frequently, but I was so overwhelmed by it all that I just cried. And I'm not sure whether that's the right thing to do or the wrong thing to do. I'm not sure whether it's right for trainees and other doctors and nurses to see that we are fallible, and actually we are human, and it is overwhelming sometimes, and we might come across as we're on top of this, but actually I did not feel on top of it at all on Tuesday. And in the middle of this, I then had to have a really important meeting, and I had to then run a quiz session and a teaching session, and the whole thing was just overwhelming. And in the end, I took, I think, about 20 minutes, 30 minutes out, had a conversation with somebody, had some chocolate always helps. I guess refocus that enabled me to get through the end of the day, but it was tough. And I think sometimes it's really important to show others as well that actually it's okay not to be okay sometimes.
I mean, that is the end product if you do not give yourself a break, if you do not manage to the end product is emotional. Some people cry, some people get angry, some people snap at other people, some people yell at somebody else. But that emotional outburst in whatever form it takes, it means you're done. It is the equivalent of the computer saying system error encountered, need to restart. That's how humans put up that dialogue. That's how we do it. And you've got to get off the shop floor.
Yeah, absolutely. I think I actually said, I'm done. I can't do any more today. And I knew I had to go back in the next day and do 12 hours. So I knew I had to somehow get home, have a really, really good night's sleep. I put some trashy film on that was absolute brain rubbish that completely took my mind off it, and then just went to sleep and slept, and then the next day was much better actually. But it's really important to recognize when I can't do this anymore. This is just not going well.
And if you keep getting to that end point and you keep having that emotional disaster, you can see how after you've had that a few times, this is when people start to become unwell. And people say, I'm too ill, actually, I can't work. And I think going off sick with burnout and all that sort of thing, so many little red flags come up on that journey before you get to that point. And it's really is beholden on us to identify those red flags and do our best. And I'm talking about in ourselves and in other people to stop this from being a repeat cycle as best as possible, and just moving that person or yourself away from the end point of saying, and we are done. I am not coming into work for a while because I'm not well. There are some warning signs before we get there, but we don't really work in a system which is programmed to identify and action something when those warning signs go up.
Because I think when you are in our job, you feel a lot of guilt about not being at work. So I'm like, well, if I'm not at work, who's doing all this and who's doing all that? And you feel guilty, and then it just escalates and escalates and escalates until you get more unwell. But guilt is also part of burnout, isn't it? And part of exhaustion is feeling that overwhelming guilt. And sometimes you need a few days off, sometimes a few weeks, sometimes a few months. It's very different for individual, but it's about recognizing that need, isn't it?
Well, I'm on call all this weekend. We're recording this on a Friday, and I've had a lovely Friday talking to you with podcast. So hopefully I've got enough fuel in the bank to power through these 2 long days on tape.
Yes.
And I know I'll go in and they'll say, there are 34 patients to post tape. Then we start at patient 1 and we go one after the other until we see patient 34. What else can we, how do you eat an elephant? You pick up the knife and fork and you start at the tail. And you can bite the life until it's gone.
Yeah. And that is what got me through this Wednesday, was somebody saying to me, you can't do everything. You may have 30 people, 40 people. So what you do is you start at exactly what you did. You start at patient one. And on Wednesday, I was like, I can't go any quicker. I can't do anything else. I'm not Superwoman. I'm just going to start at patient one and I'm going to work my way through. And if it takes me 12 hours, it takes me 12 hours.
Yeah. Exactly.
You know, and that's, as long as I'm the best doctor I can be at that time, giving that patient everything I possibly can in that moment, I am doing the best I can. And that's all I can ever wish for.
And you know that during that shift where you are plodding through it one after the other, people are going to come to you and they're going to say things like, there's still so many patients waiting.
Yeah. Yeah.
Now there are another 30 patients, and who's doing this?
Yeah.
And all you've got to do is just respond truthfully and say, yep, I'm totally aware. This is as fast as I go safely, but I'm aware of those issues. If you have any solutions, I am absolutely open to hearing it. Otherwise, I'll just keep doing what I'm doing.
Yeah.
You know, maybe I've been lucky, but I find that what if you just say that politely and honestly, people get it. And they say, okay, people, let me know that's your situation. Now we'll go back to whatever, the senior ops meeting, and explain. But what other response is there to that? You've got one pair of hands and one brain, and you do things one after the other. And
Exactly.
I think where those situations go wrong is when people perceive those questions as an attack on them and say, well, what do you expect from me? This is ridiculous. But they're asking you a question and you just answer and say, this is how we're today, and I'm completely aware of the crisis that we are permanently in, and this is how I'm working through it.
I think though, when you are tired and you are exhausted on that day and somebody says, you've still got 10 to see, come on, and I'm like, are you serious? I can't even, stop stressing me out, this is ridiculous, I'm alone. And then I'm like, oh, this is not a normal response, Amy. This is not how you'd normally respond to the situation. They've asked you a reasonable question, but your response isn't reasonable. So clearly you're exhausted and you're neuroglycopenic. I say that to my kids now. I'm like, you're not hungry, you've got neuroglycopenia. They're like, oh, shut up, Mom. Anyway, on that note, thank you so much, Ben. As ever, we've had a therapy session, which is always helpful. So thank you to all of our amazing listeners. Please rate, review, tweet, and let your friends all know about the podcast. And we'll be back very soon. Thanks for listening. Goodbye.
See you next time.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.